So thank you so much, Ajay, for the kind introduction. And then refractive surgery never enchants. It's the refractive surgery always the halls are the least occupied. So I don't think it enchants. Yet for people who have passion for refractive surgery, I think there's nothing better. And I'm looking forward. And I've tried to, in keeping in mind the topic, I've just rechristened it a little bit to uh, like this. I hope it makes sense. So,
Great.
but it'll cover basically all that as we set out to do. So, um, so should I go ahead, Ajay? Is my screen visible?
Your screen is visible, Gaurav. Please go ahead. And it
Thank
looks
you.
very interesting. The topic is absolutely perfect.
Yeah, I just thought I'll share with what all I'm doing
Yeah,
in the last
sure, sure,
year or so, that what's
sure,
different from what I was doing before, and
sure.
it encapsulates all the
And Dr.
topics.
Umang Mathur will be joining us. He's busy somewhere else, but he'll be joining us in a short while.
Perfect, great. That makes it even more interesting. So I think over the last 2 decades that I've been doing refractive surgery, we've seen we've gone through lots of things, and amongst the diagnostics, I'll just because the treatment modalities have changed as well, but the diagnostics changed drastically from 2002 when I started doing refractive surgery with just a corneal topographer and an ultrasonic pachymeter to abrometry, which we added in four, then the pentacam, which now today I can't even imagine one day without the pentacam because it disables me. And then of course refractive surgery, there is a good space for good optical biometer as well. And then we got the Vario topolizer for topo guided treatment somewhere in 2013 when the abrometry went out of vogue. And then we do use the Virion, which is for cyclotorsion in smile. We try to mark our eyes using the Virion for cyclotorsion control. And I think today, again, just like the pentacam, I would not feel comfortable without an epithelial mapping. And then, of course, dry eye. So, refractive surgery has gone from just requiring a LASIK machine and a topographer and an ultrasonic pachymeter to so much. And then we added an eye trace like 2 years back, which again today I feel is indispensable for me, and I'll show you why. And we are hoping to get a Corvus, but this COVID thing has, put us on the back foot. So this is what I started with. I have my old topographer and my pachymeter, and I really enjoyed the first few years of doing refractive surgery just with this much. And believe me, it also works. I mean, you can keep adding as many instruments as you like. Then the pentacam, which is now something which we probably, don't like to work without. So it definitely adds a huge amount. And then, of course, today, I think what's new and in the last 3-4 years that I've really got fond of is epithelial thickness mapping, because it helps you understand everything that not only in the pre-operative workup but also in post-operative follow-ups of our patients. All those surprises where you don't understand why a patient is not seeing well, or if you have a refractive surprise of some kind, or epithelial remodeling is influencing the results of a patient. It really helps you understand in the post-op period as well, and you can compare it to the pre-op maps. And plus, in case selection, it goes a long way. We are using the central middle one, that is the Avanti RT-View, which I think Kumar is also using the same one, but the newer devices like the MS39 is supposed to be amazing for doing much more. And just representative slides of what the epithelial maps could tell you. This is a keratoconus where they will be thinning on the apex. Now, this is of course an advanced keratoconus, but a subtle one would show some thinning on the apex and compensatory epithelial hyperplasia in the areas where there is induced flattening. And that's how you would pick up. So if you have a suspicious pentacam map, it always is, I would immediately fall back on an epithelium map to see why it is showing up like that. And you can pick up things like this is of course post refractive surgery, so it's a myopic ablation, and you'll have central epithelial compensatory hyperplasia. And then of course post laser correction you can get stromal maps in addition. Now this is a healing post laser vision correction map where part of it has already epithelium is hypertrophied, some areas are not, so this patient will not have great vision at this time, and over a month or two this will further develop better. And then you can pick up contact lens warpage, and you can pick up as I said, the keratoconus suspects. So that's briefly about mapping and how it's very useful to us. And then of course, now the eye trace I will not say is indispensable at all, but it does help us in many ways in reconfirming and managing our patients much better. So it combines basically a wavefront abrometer with a corneal topographer, and then also doubles up as a very high quality auto refractor. And of course, it gives a lot of other things like the angle kappa and the angle alpha as well, which is useful for both cataract and refractive surgery. So essentially, I think most of us understand the application. Now, I delayed buying an eye trace almost by 3-4 years, thinking that it won't be fit into my practice. But once we got it, I think it's indispensable as well. And it helps you identify essentially the origin of the aberrations, whether it's from the cornea or the lens. And I'll just show you a couple of cases. So this is a dysfunctional lens index, which I find very, very useful today, because in a person with minimal lenticular changes, this would be, say, in the ranges of 7 or 8 at least. But if you see something like this, it tells you that there may be more. The corneal aberrations are negligible on the left, but the internal aberrations are significant. Now, if a refractive surgery patient shows you something like this, then you immediately know that even if you did a good LASIK or a SMILE or an ICL, this patient will not do well. Quality of vision will not be good at all, because the internal aberrations are very high. Also, of course, for multifocal IOLs and other stuff, and you can use these things. Uh, the Chang analysis, which helps you decide about the corneal aberrations versus the internal aberrations, that tells you all the orders of aberration. So this helps you understand aberrometry. Now, I can't go into the details, but this will be a representative case which will help us understand better how an eye trace can be very useful in a refractive practice. Lady, a 25-year-old girl with the refraction in the right eye, she had anisometropia, -20 with a 3.5 cylinder in the right eye, and a 5.5 with 1.25 in the left eye. And on clinical exam, everything looked fine. The axial length, of course, would be different in the two eyes. The right eye best corrected vision was just about 636. On clinical exam, there were no significant changes suggestive of any lenticular abnormalities, but the retina was not looking healthy at all, and we were considering that right eye, what should we do, because it was beyond the range even of the star ICL at least. And in the left eye, of course, it was looking like amenable. These were the maps. Now, when we looked at the maps, it became clear that the pachymetry was very thin, and this patient was not going to be fit for even in a LASIK in the left eye. So both eyes needed some intervention. The AC depth looked fine. It was 3 millimeters here and 3.37 in the left eye. These were the epithelium maps for the two eyes. Now, this is how the eye trace looked. So this is of the left eye. And if you notice, it looks amazing. There's a 10 out of 10, which means the lens is absolutely clear. So this is a very good thing for a refractive surgery. When we looked at the other eye, the right eye, which was anisometropic, this is how it looks. So you see that the corneal aberrations are negligible, but the internal aberrations are so high, and the dysfunctional lens index is almost 1.2. So while there was no evident cataract for this patient on slit lamp exam or anything, but somehow the lenticular aberrations are very high. So we went ahead. This is how it looks. So if you look here, left eye does not see any potential visual complaints. But if you look at the right eye, it shows you all the things like night myopia, blur and glare and halos and everything, if we were to proceed with a surgery. So we went ahead. This was the biometry. Of course, we always do an optical biometry for all our patients. It showed in the right eye 2.5 diopters in case we wanted to do a clear lens extraction with a small toricity. So we actually went ahead with a refractive lens exchange in the right eye because of the DLI being so small, and of course with a guarded prognosis. And you can see that post-op, can you see how the DLI changed completely with pseudophakia, which shows very clearly that the corneal aberrations were negligible, and we've sorted this. And this patient's vision was improved to 6/9 parts in the right eye. And this left eye, we went ahead with an ICL, and that eye also did well. Patient was 6/9, and frankly, the patient somehow started liking the right eye, which was always thought to be the amblyopic one. And had we gone ahead with an ICL, we would have probably in the right eye had just about 636 or 624 vision. So that shows you about how easily, an eye trace kind of a device or similar device like the OPD scan or something can be really, really useful in this situation. Another patient who was having this kind of a refractive error with about 2.25 cylinder in the left eye, small corrections. And we noticed this inferior steepening in the left eye. The right eye maps were fairly good, and the bad maps were again pretty good, but that inferior steepening stood out, and we did the epithelium maps, and in the right eye they were good, in the left eye they were fairly good. So all other things done, we thought of what should be the treatment plan. We called the patient back after 15 days of using lubricants, repeated the pentacam maps, repeated the topography. The topography and pentacam both showed up that inferior steepening in the left eye. So while the correction was really small and everything looked great, we decided not to go with a flap, and we went with a surface ablation for this eye. And such situations can be easily, whenever in doubt on a cornea with one of the tests, you can easily shift to the surface if the correction allows it. So where do we stand with surface ablations today? We've come a long way with surface ablations from the time we started doing them in the 90s, because now haze is extremely rare with all the mitomycin protocols that we use. And we have great understanding of, how PRK can be best dealt with, because now we don't see those regressions which we used to see in the early days with the broad beam lasers. So the refractive stability is excellent. So what does hold us back from doing more PRKs? I think the one thing which probably still holds us back was pain and discomfort, which again has probably got sorted quite well in the last 2 years that we've started using ketorolac preservative-free, soaked contact lenses. So I was in 3 years back, I was in Narayan Nitrale for a meeting, and we first saw this being used there. And I started my studies at that time along with the Narayan Nitrale group, and we did, some 30, 40 eyes to begin with, and we found a tremendous difference in the pain control of the patients. So that it has now over the last 2 3 years that we also cross-linking. We use our patients with BCL soaked in ketorolac, and it works extremely well. And these eyes look absolutely clean. Patient, we don't even counsel patients about that they will have extraordinary pain or discomfort following PRK as compared to our LASIK and SMILE patients. So it's again we used quite a bit of surface ablations today, and since AccuVel is no longer available, we now use this. We actually had to request NTOT to start making this drug similar to AccuVel because it comes by the name of AccuSaid. So we just soak this for 5 minutes. Narayan Nitrale groups does it for 30 minutes. I just soak it for 5 minutes. It works beautifully well. And then we just drain out the, contact the solution from the thing and replace it with ketorolac. And then at the end of surgery, we just replace it on the cornea. So going on, I think some of the other very important steps with doing good PRK is chilled BSS irrigation right after the ablation and mitomycin applications. I use the protocol which was, kind of sorted by Parag Majmudar's group and Randy Epstein's group about 20 years back. And I use it 0.02% for 12 seconds if my ablation is less than 50 microns. And if it is more than 50, I don't ablate more than 90 microns usually. So then it will be 30 seconds. But the LVP group does it for 10 seconds per diopter of ablation. So they don't go by the microns, they go by the diopters. And they actually treat PRKs right up till 9 or 10 diopters. I don't go beyond 90 microns of ablation, which is maximum of 5 to 6 diopters. But for me, my PRK works extremely well. So for many years, I was using the Amol's brush, and this worked very well. Almost 15 years now, I've been using the Amol's brush for my epithelium removal, and it worked well. But last few years, we've moved on to Trans PRK. For many of our cases, in fact, majority of our surface ablations are now with the new Streamlight software on the EX500, which is what you wanted me to talk about. And so for this, the only thing I will say is that for Trans PRK to be done correctly, epithelium maps are critical, because if you don't have you not only to know about the epithelium thickness as such, because we can't go by the thumb rule of 10% of the cornea thickness and set it at 50 for every patient. Some corneas with 550 thickness will have only about 46, 47 microns of epithelium, and others with just 480 corneas will have 55 microns. So you can't go by a generalized calculation. Also, you have to see the uniformity of the epithelium, because it may be in the center, it may be say 53 or 54 microns, and just a little bit in the mid periphery, it may be thicker or thinner, and then you can have a poor outcome. So anybody with irregular epithelium thickness, you can either go make a flap and do a surgery under the flap, or you can use epithelium debridement using either alcohol or a brush, but not Trans PRK. So the advantage of Trans PRK is that epithelial healing seems to be much faster, because it's a very controlled optical zone where the epithelium is removed, and post-op pain is much less, and the visual rehabilitation of these patients is much, much smoother and faster. And it's a great value addition to PRK. This is how the PRK, Trans PRK thing looks. You can feed in the thickness at 55, for example, in this patient, and then you can just go ahead with the both eyes planning, and you can, it's basically a no-brainer. You can just kind of ablate. The important thing is that you should not leave the redundant fluid on the surface if you are washing the cornea, because that will change your ablation. So you have to set up a nomogram of how wet or dry you are going to start with on the cornea. So typically with a soaked, sponge which has been soaked and then squeezed, I just gently wipe once or twice and may remove just the extra fluid on top, but I will not dry up the cornea too much. And then you can go ahead with the ablation, and initially it is the epithelium, and then the actual ablation happens. And I'll just bypass these slides. So the patients look extremely happy. So this patient was operated the previous night, and this is after 12 hours. And you can see that so, in the past, we used to have So in the past, we used to have patients, having lid edema, corneal edema. I mean, they'll come back with epiphora. They're not happy to open their eyes and all. And now they read 6.6 or 6.9 on day one post-op, and you can hardly differentiate from your smile or LASIK patients. That's what I wanted to convey. Post-op regime, I think, is a standard PRK regime, so I won't go into the details, but steroids are very, very important, and UV protection. These are two important things. And these are the streamlined details, which I will not go into the details. Coming on to the other thing on the EX500, which we regularly use and has become really popular with patients, especially, and they come demanding for this. For the first 2 years that I was doing Contura, I started doing this about 5 years back. We were not even marketing it, and we were doing it, for our own kind of satisfaction. And then we suddenly realized that patients suddenly wanted to come and get Contura while we were trying to do Smile for them. And then we started, kind of marketing or whatever, like at least advertising in our own center that we do Contura as well. And many patients still don't believe that we do Contura. We've been doing it for 5 years because I think only a couple of centers in the country do Contura vision. So it's a very good system. And you can see that the ablation profiles, if you were to do an ablation assisted surgery for this patient, would probably show an ablation like this. But if you were setting up a topography guided, it would actually correct the steeper areas and leave out the other areas. So these are the good maps which can be corrected very nicely with Contura treatments. So it's basically a topo guided treatment for virgin corneas, and it received FDA approval a few years back. But the good thing is that these trials showed that even in virgin eyes, Contura treatments were, better than the wavefront optimized treatments. So this is how Contura was born. So Contura is nothing but a topo-guided treatment attempted on, virgin eyes, and it showed some benefits because it has good cyclotorsion control, and it, treats on the apex, on the visual axis rather than treat on the center of the pupil. So all these things led to, gain in visual acuity. So this is one of our patients, and of late, we started doing Contura, as I said, 5 years back. But what has changed in the last year is, or year and a half, is that during the lockdowns, we started doing Forcity's software-assisted planning, and it really tremendously changed because Contura planning is everything. You can, buy a machine and do what you want, but the Alcon nomograms were not really, translating into amazing benefits for the patient, and there was a lot of confusion whether you should treat this patient or not treat this patient with Contura, and half of them used to actually leave out after doing all the planning. But this all changed once we got Forcity. So I'll just show you an example. This was one of the patients that we treated, and you can see that these are the maps for this patient, and this is the eye trace, and you can see that the corneal aberrations are high for the astigmatism. So this is how the Forcity's planning software looks like. What it basically does is you will feed in the manifest diffraction over here on top, and then you'll feed in. So you take a scan on the topographer, which is the topolizer vario, and that picks up its own calculation of how much is the corneal astigmatism. So the Contura, the recommended treatment is based on the topographer analyzed astigmatism. So it leaves out the sphere, but it picks up the astigmatism only. So this is showing 1.88 at 4 degrees, whereas our manifest is 1.5 at 170. So there is obviously some difference between the topographic and the manifest, and again some difference in the axes. So both are fed into this Forcity's engine, and then it also imports data from the pentacam. So it will take the anterior astigmatism and the axis, and it'll take the posterior corneal astigmatism and its axis, and then it calculates a treatment plan for whether you should do a Contura or you should do a wavefront optimize, or whatever. I mean, there are 2-3 options that are possible. So once it has done this calculation, at the bottom, it shows you what you should do. So if you'll compare, our refraction was 7.5, but it is recommending we do a 7 diopters, and our manifest was 1.5 at 170. But using this other data, it is recommending that we do a 1.38 at 5 degrees. Why the difference? Because it also takes into account the posterior corneal astigmatism and the anterior astigmatism from the pentacam. So these have been amazingly good, our outcomes. So it also calculates the talus. These are the taluses, which it picked up, and that these are the areas where, the abnormality is there, and it comes out with a treatment plan for the topo-guided treatment. And these are the vectors for that. So I won't go into the details because this requires a full 1-hour session. And however, this is the second eye, so similar planning, and I won't go into the details, but essentially what I'm trying to convey is that the Contura results have been tremendously good. Now, the only thing I will say here is that Contura is great when it is required. You should not be doing Contura on every patient who walks into your clinic. only about maybe 10 to 15% of patients of all your refractive practice actually are going to really benefit from a contour assisted treatment, and others may not really need it. So very high corrections, very small corrections, negligible astigmatism, minimal corneal aberration, there it is like a overkill. It doesn't really help. But for cities software, which is basically by Mark Lobanoff, he's it's free for people in India to use, but it's very expensive if you use it abroad anywhere. For now, it is free for Indians. So if anybody wants it, I'll help you get this onto your systems. So I think for us in our practice, Smile is fast replacing LASIK. In our refractive practice, we've been doing Smile for about 5 years. And just in 2017, I actually spoke in a course at ASCRS in Dr. Chitra's course that why I'm not doing Smile yet. And that month itself, when I came back, I ordered a Visumax. And our apprehensions were basically the limited range of treatments at that time: no hyperopia, no pure cylinders, no mixed astigmatism, no cyclotorsion control, all the things which are hyped about Smile by the people who don't like to do Smile. No customization options and less reported wow factor, the problem with doing enhancements, and no FD approval, and cost and click fee. And of course, all these things are real. I mean, most of these things are actually genuine. But for me, what changed and why I went into Smile at that time was the ability to go flap free, which was really appealing. And because of the better corneal biomechanics and negligible precautions that these patients, I had been studying Smile for almost 3 years before I actually went into took this step. And being in a small city, it was a very, very difficult and challenging decision because the financials were going to be crazy. But no, lesser dry eye and the long-term visual results were at that time as good as LASIK. Today, I would say that long-term stability with Smile is much better than with LASIK as well. And then, of course, 5 years back, we got FD approval. And of course, all people who do refractive surgery with a flap will be aware of all these things. And, first day post-op, you always sleep thinking that tomorrow morning, if you've done 7, 8 cases, then you don't want to see any of them have the slipped flap or other stuff, it's dry or something. And we often deal with these flap complications. But with Smile, frankly, I've been doing it for 5 years. There's almost only 2 or 3 patients in 5 years that where I had actually interface or, other complications, and almost no incidence of these flap complications. And of course, now I won't go into the PRK pros and cons. This was basically from another talk that I picked up this slide, but this is comparing Smile and PRK. But with Smile, the corneal biomechanics are definitely superior. That said, I would still think that PRK still has the best biomechanics, because even though Smile is way superior to LASIK when it comes to corneal stability and risk of ectasia, but because it preserves the Bowman's and the anterior stroma, yet I still feel that PRK might hold the best, stability of the cornea. So where indicated for smaller corrections, I will still choose PRK. So for very small corrections, I still don't want to do Smile. I still do a PRK. Dry eye, there's a vast difference. These, sometimes there are patients where I do one eye Smile and one eye I do Contura because there's significant astigmatism or other stuff. And the patients with the Smile eye, they kind of feel so comfortable even with a week down out of surgery. And the other eye takes almost a month before they feel comfortable. So there it's a good comparative analysis between the two eyes. So today my Smile surgery would look something like this. It's a bit fast forwarded. So that's the second interface. I first dissected the cap and now it's the lenticule dissection. And there you free the lenticule and just kind of deliver it out. You don't need to go in with the forceps really, and that's over. So sometimes you'll have these complications. You're trying to get a forceps inside. So, you'll tend to, sometimes if your flap is not fully dissected and you can have a cap tear and you can have other complications, and you must have seen these videos. They're extremely rare, of course, but because they are still possible, we, I designed this small cannula, which, makes it life very easy. I'll take you to the end of this video. So once you've dissected the flap, all you have to do is do a hydro expression, just like you do maybe in a SICS with hydro expression, or you use it for some other technique. So there's a special cannula that I devised, and it's kind of shaped to accommodate the cornea. You just go and put a gush of fluid at 6 o'clock, and the lenticule just pops out and makes smile surgery much safer. So many people are using this now. And our refractive practice over the years, when we started in 17, I think only 35% was smile. There was a lot of excitement, but gradually it has grown to almost 65% of our practice today. Femto LASIK actually went down because smile took on. So our total LASIK volumes have been crashing and smile has been replacing it. So all indications for LASIK, except those which require a contour treatment, we tend to now move them to smile if possible because the parameters and the guidelines are the same. Microkeratome is almost finished. Just about 6% is microkeratome, but PRK improved from just 10% in 2017. It improved to almost 18% next year. And then gradually we've seen it stabilize at about 12%. So PRK still holds a good sway. And I think I'll just bypass that. So are we really smiling? We've done about 3,000 procedures in 5 years. And I'll bypass this slide because I think we are short of time. So case selection is the key to success with smile. And during the learning curve, it's good to avoid very low and very high corrections. Avoid astigmatism initially beyond 1.5 to 2, but with good cyclotorsion control now and on the Virion. Using that, we now actually, stabilize and try to do correction for the cyclotortion as well. So it has helped us, and we now routinely do astigmatism even beyond 3.5, 4 diopters. And for high corrections, actually, smile is very good because the corneal stability and the stability of corrections long term seems to be a little better with smile as compared to LASIK. And the wow factor, frankly, after the first 100 eyes, where you typically get occasional refractive surprises, and the 6.9s and 6.12s are more common. Today, almost all our smile patients are 6.6 unaided on day one, and you can't make out that you actually did a surgery. And the best part is when you finish the surgery, you don't have to tell the patients about any precautions. You sometimes I think what to tell them, like what not to do. With LASIK, we have to tell them almost everything. Don't sleep like this. Don't touch your eyes while putting your drops. Be careful and don't dislodge your flap and stuff. With smile, from the time you finish it, patients don't have any red spots. There's almost no lacrimation, edema, photophobia in the morning. And from day one, they are usually 6.6 or 6.9. And yes, the near vision takes a little more time with smile to stabilize because I think the cap irons out a little longer. So compared to our LASIK patients, the smile patients, their near ability takes almost a week or two to recover properly, but LASIK patients might recover a little faster. So also because of the milder suction and patients are able to fixate, so the centration of treatments is pretty good. And post-op precautions and healing are negligible. That's the best part. So some girls who want to get married or some other patients who are on the go from the day one or day two, I almost always end up doing smile because eye makeup and all those things you can start doing within few days of surgery. And rehabilitation is very fast. Their visual results have stabilized now for most of our patients, as I already told you. And the only thing missing now is the hyperopia, because even the pure astigmatism you can actually treat with the new nomograms, and I think hyperopia should become available soon. I think smile patients send back many more patients. They just love the procedure. They are very happy and the positive vibes are pretty strong. And from the surgeon perspective, I think it's what's important. I'm finishing in 2-3 slides more. You feel more confident offering a safer surgery to the patient because lesser of ectasia and less flap complications. So I think it really helps, and it's a single step procedure and minimal precautions, as I said. From the patient perspective, I think safety, minimal discomfort, minimal precautions, quicker rehabilitation, and long-term safety from risk from ectasia and everything is much less. So I think from there as well. And for both my children, I've done smile over the last 3-4 years. So that kind of probably conveys that my confidence with the procedure. Our enhancement rates with smile are much lower than what we have had with LASIK over the 20 years that we've been doing LASIK. So just about 0.1% compared to a 0.63% with LASIK over the years. Probably because LASIK has been also there for longer. So maybe some of our LASIK patients coming back after 15 years now seek enhancement. So when to choose PRK over smile and LASIK? Small corrections below 2 diopters. Suspect corneas, we do occasional PRK extras. We do a lot of topo-guided PRKs with CXL now for our keratoconus patients as well. And they seem to work extremely well. We've been using the Faucet's for that as well. And corneal pachymetry less than 490, I would like to switch to the surface. Patients who are very anxious about risk of complications with LASIK and smile. Some aspirants for armed forces who don't want any mark on the cornea. So a lot of indications for PRK even now. When combining with cross-linking, I usually don't like to do combined treatments with LASIK or smile. When to choose LASIK over smile? Hyperopia, high astigmatism, where you might want to do a contura, patient is not able to afford, and for highly aberrated corneas. I think I'll skip phakic lenses. Kumar is going to speak on that, but for phakic lenses, I'll just show that we have been doing small corrections as well. So now we have very small corrections, which if we have a suspect cornea, we don't hesitate to use a phakic lens. And with that, I think I'll stop here. To summarize, refractive surgery has come a long way since we started almost, refractive surgery came up 30 years back. I've been doing it for 20 years. I remember going to Sanjeevan Nursing Home as a PG, observing, few surgeries where in the mid 90s, and that's where my passion for refractive surgery started. A lot of new devices have been available now. The diagnostic devices give us a lot more information, and our patient refusals have gone up because of this. And with more the devices, the more number of patients that you tend to refuse for surgery. And uh, a choice of procedures is now available, and each patient should be dealt with differently. There is no one procedure which fits every patient, and it's best for a refractive surgeon to have all options possible available, or you can go and operate somewhere else if you don't have a particular thing, but you should be able to offer all these treatments as well. So it's exciting times for refractive surgeons, and thank you.